well, we should get started. So welcome everybody to Medical Grand Rounds, a very special Medical Grand Rounds. Today is Dr. Sarah Donahue, who, as all of you know, is our Page Family Endowed Chief Resident. Dr. Donahue graduated Phi Beta Kappa from the University of Wisconsin in Madison with a dual degree in Spanish and Latin American Studies and a certificate in Gender and Women's Studies. As an undergraduate, she received the Louise Traxel Award and the Wisconsin IDEA Undergraduate Research Fellowship. And before starting medical school, she worked as a research specialist in the Carbone Cancer Center here, where she worked on the development and conduction of breast cancer clinical trials. She continued in Wisconsin, at the University of Wisconsin, for medical school, and she was elected to the Gold Humanism Honor Society and AOA. She was also the recipient of the Shapiro Excellence in Student Research Award and graduated with honors in research. She has been very productive with 6 publications, of which she's the first author on, and has presented her work nationally. As a medicine resident, she was awarded the Chief's Award for embodying the residency's values of collaboration, volunteerism, and education twice. And as chief resident, she's worked on creating a residency mentoring and coaching program and development of a women in leadership and development curriculum. We are lucky that we're able to continue to recruit Dr. Donahue. She's going to be a rheumatology fellow in our own program, and with a focus in clinical education and working towards addressing racial and gender inequities in medicine and within our community. So today we are delighted to have her talk to us about history and herstory. I love that. Exploring gender bias in internal medicine residency training. So Dr. Donahue.
Thank you so much for that lovely introduction. I'm going to take you back to 2017. 2017 was a pivotal year for me. 3 major things happened. I matched into internal medicine residency. I graduated from medical school, and I married the love of my life. And despite all of those momentous occasions, there is one particular day that stands out to me. In the spring of 2017, I was on a lighter M4 clerkship and had a golden weekend. I traveled to Milwaukee with my mother to try on wedding dresses. As we arrived to the boutique, I remember thinking to myself, this is a big day. Think Randy Finoli, say yes to the dress, big day. And as we were in the bridal boutique and looking and perusing at different options, my mother picked out dresses for me to try on, and I obliged. In the dressing room, I was working with an attendant, and she started to make small talk and asked, so what do you do for work? And in my very energetic M4 phase, I responded, I'm about to graduate from medical school and start my training in internal medicine. She took a step back. Her face went blank. She looked at me from head to toe and then nonchalantly responded, oh, I forgot. Women can be doctors. I forgot women can be doctors. And in that moment, a complete stranger was able to fracture my identity and negate everything I had worked so hard for over the last decade of my life. And I know there are many of you in the virtual audience who are resoundingly shaking your heads yes, that you too have experienced such gender bias in your personal or professional lives. And this is far from the most egregious act of cognitive bias or gender bias that I have received in my times of training. But it is one that stood out. And those words are stuck in my memory. I forgot women could be doctors. So today we're going to take a self-reflective journey. And to get this self-reflection kicked off, I'm going to have Clint go ahead and launch a poll questions for us. So in the center of your screen, you should be seeing 2 poll questions. Depending on what type of device you're on, you might need to scroll in order to see the full second question. These are completely anonymous. And the first question reads, when was the last time you faced gender bias in your personal life? And the definition of gender bias is a comment or an action that was directed towards you as a consequence of your gender. So think about that for a second. And then scroll to that second question. When was the last time you faced gender bias in your professional life? So go ahead, fill out the poll. You can submit the answers. We'll give it just a few more seconds. And then I'm going to have Clint go ahead and close the poll and launch the results for us. Now you should be able to see the results in the center of your screen. And what you can see here is that there is high variability. Some of you have experienced gender bias in your personal or professional lives as early as yesterday. And some of you never have. And I want you to think if we were all together in the VA auditorium, having those donuts and coffee, and you look to your left and you look to your right, someone next to you could be experiencing gender bias on a daily basis. And this much more significantly impacts women in medicine. So Clint, I'll have you go ahead and close the poll for us. Great. So I have 4 learning objectives for us today. The first is that I want you to be able to recognize how print and social media, pop culture messaging, and societal gender normativism all impact the psychosocial development of our female residents. Next, I want you to be able to describe the pipeline model as it leads to a paucity of female leadership in the highest echelons of academic medicine. Next, I want you to be able to identify, and I want you to be able to identify how the female internal medicine resident trainee experience and career advancement is starkly different from their male colleagues. And finally, I want each of you to develop your own toolkit so that we can all move forward towards the advancement of women in medicine. My talk today is going to be divided into 5 parts. First, we'll go through an introduction to gender bias. We'll move into the pipeline model. Then we'll evaluate the trainee experience, career advancement, and finally, ways in which each of us can improve gender equity in training. I want to start with a normatization statement. Today, I'm going to be talking about gender bias and disparities as they occur in internal medicine residency training. But I want us all to remember that there are many forms of bias, disparities, and discrimination that occur within academic medicine, all of which deserve their own platform and their own grand rounds for further exploration. Next, I want to say that gender is a societal construct propagated by stereotypes, expectations, and assumptions. Today, I'm going to be speaking of the genders in binary terms, male versus female, but that is in no way, shape, or form in alignment with the most current practices in society or the social sciences. However, we in the medical literature have yet to catch up. And finally, I want to say that this talk is not aimed at men, nor is this an attack on men. This talk is aimed at society. It's aimed at our medical community and graduate medical education. And I simply want to open the door to conversation and make sure that that door stays open. So now we'll move into looking at the impact of gender bias in medical training. 2020 was an important year for many reasons. And for once, we're not going to be talking about the pandemic. but rather what it means to self-identify as a female in the modern era of medicine. And in order to understand the modern era of medicine, we actually have to understand all of the different movements that have been occurring both in person and on social media platforms. And these include the campaigns like "I look like a surgeon," or the movement to end manels, also known as all male panels. And finally, the he for she movement. But despite all of these momentous ideas and progressive forward nature to advance women in medicine, women still continue to face gender bias on a daily basis. In December of 2019, the Journal of Vascular Surgery published a manuscript entitled "The Prevalence of Unprofessional Social Media Content Among Young Vascular Surgeons." This study ignited a fire. The predominantly male authorship utilized predominantly male medical students and vascular surgery trainees in order to create fake social media accounts across 3 major platforms, including Twitter, Instagram, and Facebook. And then with the use of these fake accounts, they searched and screened for publicly available information regarding vascular surgery attendings and trainees. They identified 486 accounts. And unprofessional social media content was defined in many ways, but one of the most significant was regarding provocative attire, which became known as bikinis. And this led to quite a splash. The study was later retracted in July of 2020, after the movement of #MedBikini came forward. And the study was retracted because of the significant errors that existed in the methodology of the study. The study authors used antiquated norms in order to identify what was deemed to be unprofessional social media content. And the content that was found was more so indicative that women had unprofessional social media content available publicly. Again, this made quite a splash. And we saw significant intersectionality of the med bikini movement in addition to body shaming. There was some humor in there with what it means to have appropriate work attire and uphold professionalism always, both at work and during personal time. And then finally, intersectionality with the "everybody is a bikini body" movement. And then in October of 2020, a very popular medical attire company produced the following video, which was available on all of their social media platforms. And the video was out just long enough to be captured and for images to be recapitulated. Now, I don't need to state the blatantly obvious. The American Association of Colleges of Osteopathic Medicine released the following position statement: that they were outraged that in 2020, women physicians and doctors of osteopathic medicine are still attacked in thoughtless and ignorant marketing campaigns. So what does this mean to the psychosocial development of our female trainees? And I want to take a step back and talk about gender schemas. Now, gender schemas are mental structures or scaffolding that each of us innately have, and they allow us to interpret incoming information and in turn perceive that information. And often this can lead to stereotypes, assumptions, and expectations. We're going to do another thought exercise. So I'd like everyone to go ahead and open their chat. Now you can either find the chat feature in the bottom center of the screen or under the 3 dots that symbolize more. And I'm going to pose to you the following question, and go ahead and write your answers in the chat. The first is, when thinking of the binary terms, what words does society commonly use to describe men? macho, strong, distinguished, strong, breadwinner, professional, leader, perfect. So you guys are identifying significant words that are used in society. And Dr. Carnes and colleagues in a 2015 study elucidated the following terms. Men are described as logical, strong, action-oriented, and finally agentic, or capable of independent autonomous action. So let's go to the chat again. And when thinking of the binary genders, what words does society commonly use to describe women? Caring, nurturing, accommodating, team player, motherly, emotional, perfect. I'm seeing a ton of great, sweet, compassionate, caring. Wonderful. Thank you guys for all submitting to the chat. So Dr. Carnes and colleagues found the following terms associated with women: kind, nurturing, dependent, and communal, or selfless, caring for the community around oneself. Now you can see the juxtaposition and the dichotomy that exists between these terms. Men and women in society are looked at very differently. And how does this apply in practice? So Dr. Isaac and colleagues performed a study where they evaluated 297 medical students' performance evaluations, also known as MSPEs or the Dean's Letter. Now, these were 297 medical students matching into diagnostic radiology. Approximately 220 were male and 70 were female. And the study authors used linguistic software in order to identify key factors or factor syntheses to describe the information that was found in that of a letter of a male versus female. And they found the following information: that male medical students were often to be described as working eagerly and responsibly, above expectations, and toward becoming an outstanding, insightful specialist. Whereas female students were described as working hard and enthusiastically, asking insightful questions, and will make a capable physician. Now there's another dichotomy here. We see that men are being described as more logical or capable of that independent, autonomous action. And then female medical students are being described as more dependent and kind, and will make a capable physician. Now we know these are resoundingly not true. Our medical students can match into any field that they want, but this gender normative language and gender schemas can come into play. And how does this apply in internal medicine? Well, Dr. Carnes in a 2015 study described that within internal medicine, there are actually 3 subspecialties that are considered to be more communal. Again, caring for people outside of yourself, for your community. And these include geriatrics, endocrinology, and rheumatology. And then when you look at the AAMC data, the physician specialty report from 2019, this is looking at the level of attending physician. You can see that within those 3 communal specialties, they all approximate or are nearly above that 50% mark for percentages of females. But then when you move into the more agentic specialties like cardiology and even more substantially in interventional cardiology, you can see the precipitous drop of females. And why this is important is because representation to our trainees matter. Role modeling to our trainees matter. And what I want you to take away from this first portion of my talk is that language is key, that words matter, role modeling matters, and representation matters. So now we're going to move into exploring the pipeline model. And first I want to describe critical mass theory. So critical mass theory is borrowed from nuclear physics, and it states that we need a particular amount of a substance in order to initiate a chain reaction. Now this has been hypothesized and applied within the social sciences and within politics. where it was hypothesized that if 30 to 35% of politicians or legislatures were female, that more female-friendly or family-friendly policies would be passed. This has also been explored in academic medicine, with the thought that if 30 to 35% of faculty within a department were female, that this could lead to a substantial cultural change. Now let's apply this to the pipeline model. So what the pipeline model does is it shows us the entire trajectory of an academic medicine career, starting from medical school and then getting all the way up that leadership ladder to those highest echelons, including division chief or chair or dean, those very high leadership roles. And what you can see is that we have approximate equitability between men and women when entering medical school. But as we go through the pipeline, you see a lower inflow of women and a higher outflow of women, and that the pipeline leaks. And we see our first leak during medical school. There is a loss of attrition of women during medical school, which leads to lower graduation rates. And then when we see the highest outflow and the biggest leak is actually within the levels of the professorships. Now, this has been studied and hypothesized for many different reasons. And thoughts include that gender climate plays a significant role, pay compensation, in addition to lack of promotion of women in medicine as compared to their male colleagues. There's also work-family conflict and many other reasons, including going into private practice, which can lead to an outflow of women in medicine. And then we see that final leak at that very highest level of division chief or chair. And what does this look like numerically? If you look at the AAMC, the State of Women in Academic Medicine report from 2018 to 2019, you can see this national representation. Females are identified here in this blue color. And again, we see that approximate equitability with entrance into medical school. However, we then start to see lack of attrition with less women graduating from medical school, entering into residency, fellowship, and then into the faculty positions. Then we really see that precipitous drop down to the full professorship level for the various reasons that I described. And finally, the downward continuation to the level of a department chair. And so I was intrigued by this information, and I wanted to know, how do we compare in our own Department of Medicine? So looking at internal data from the School of Medicine, as well as our own department, I found that we are actually doing quite well. National data is represented here in blue, and UW is represented in red. And we matriculate more female medical students than the national average. We break dead even at the level of residents, but we have more female faculty, more female full professors, and division chiefs. And we are off the charts, as we are so lucky to have just welcomed our first female department chair, which sets us kind of off the charts when looking at our single department. And what I want you to take away from this second portion of my talk is that representation is key, that we need to create equal opportunities. We need to assess and revise the culture in which we work and live. And we need to increase visibility. Now we're going to transition into looking at the trainee experience. There are 1,440 minutes in a day. And what we're going to do in this portion of my talk is walk through the day in the life of a PGY2 or a second-year internal medicine female resident. And I want us all to remember back to that second year of our training. You're no longer at that beginning stage or an intern, and you're not yet at that final stage or a senior. You're somewhere in the middle. And that's so important because that second year is when we really transform into our own leadership styles, our own autonomous ability to care for patients, and our directive communication. So let's all try and think through stepping in the shoes of a female resident for a day. Your day starts abruptly at 6:30 a.m. You enter the hospital to start work rounds with your intern. You enter the first patient room and the patient is on their cell phone and they loudly state, "Oh, good, my nurse is here to bring me breakfast." Now, in that first 5 to 10 minutes of your day, you've already experienced gender-based professional misidentification. Dr. Berwick and colleagues at Beth Israel studied this, and in a survey study of 186 internal medicine, emergency medicine, and general surgery residents, the study authors found the following: that gender-based professional misidentification can also be known as a mistaken identity, and that females are misidentified at least once as a non-physician by a patient or family member 100% of the time during their last inpatient ward month. Now, this is in juxtaposition to 44% of their male colleagues. And this mistaken identity can lead to a change in mindset, including annoyance, anger, and decreased job satisfaction. And so in order to offset that mindset, female residents have behavioral responses, including changing the manner in which they dressed or introducing themselves with the title doctor. Now, I know there has been a movement to flatten the hierarchy and to do away with wearing the white coat, but I would heed you to reconsider that. For many female residents, the white coat is the only shield that protects them from microaggressions, being called things like baby, sweetie, cutie, or macroaggressions like patient-perpetuated sexual harassment. So that white coat can be important. So you remind yourself to introduce yourself with a title doctor and you move on to the next room. In the next room, you have your intern start the history and physical. And you look at the vitals for the patient and start looking at the I's and O's. Next, a nurse comes in and starts to open a Foley catheter kit. They open the kit, they place it at bedside of the patient and start to reposition the patient. And in this moment, you have 3 options. You can 1, request that the nurse return in 10 minutes. 2, offer to step out and return in 10 minutes to complete the exam. Or 3, step aside and take the opportunity to talk with the patient until the nurse completes the catheter placement. Now, Dr. Bartels and colleagues looked at this very question. And in a 2008 mixed methods study, using both questionnaires and then in-person interviews, the study authors were looking at various assertiveness levels among male and female residents. And what they found was that female residents were far more likely with this question to select option number 2, offer to step out and return in 10 minutes to complete the exam. Now, of these 3 options, this is the least assertive. Option number 1 is the most assertive, and option number 3 is moderately assertive. And male colleagues were far more likely to choose options number 1 and option number 3. And the study authors also analyzed patient communication and found that female residents have much more significant perceived stress when it comes to assertiveness levels and patient communication, which can lead to what is called role incongruity, where females have to violate their gender norms in order to fall into a role that may not feel natural, such as being more assertive or directing patient care. Next, the code chimes go off. You happen to be carrying the code pager. You get your ACLS pocket card out and you head to the code. Now, in a 2014 study performed by Dr. Kolamainen here at our own institution, she conducted 25 semi-structured telephone interviews across 9 different internal medicine residency training programs, and was specifically looking at effective communication skills during cardiopulmonary resuscitation. And what the study authors found was that ideal code leader behavior was described as the following: an authoritative presence, speaking with a deep, loud voice, using clear, direct communication, appearing calm and with emotional control. And in order for women to enact this ideal code leader behavior, the study authors found that there were specific strategies that females used, including wearing that long white coat, having a badge that reads resident physician, adopting a powerful code stance, including chest pushed out or arms crossed, and finally tying or pulling hair back. And in order for women to do these things and enact a more agentic leadership style, sometimes we have to face what is called stereotype threat, where we fall into a role that might not feel as natural for ourselves or those perceiving our leadership style. So you get ROSC and the patient transfers to the TLC. Next, you remember that there's morning report, which is one of your favorite times of the day. And you head to morning report. You start to hear the case. And as you're answering some of the review of systems questions with a back and forth rapport with the chief resident, you start to notice that you are being frequently interrupted by a male colleague. Now, in a 2021 study performed at the Brigham and Women's Hospital in Boston, Massachusetts, their internal medicine residency program looked at just this. By performing a cohort study and analyzing 50 of their most recent morning reports, the study authors identified how residency conference interruptive behavior occurs. And they found that men interrupted more often than expected based on attendance and assuming gender equal participation. The study authors then went to the social science literature and found that interruptions are commonly perceived as negatively, as very much a mode of dominance or kind of a power stance. And the study authors hypothesized that gender norms regarding listening and active listening versus speaking and turn taking were very much at play here. So you're frequently interrupted by a male colleague and you decide to leave conference early. 2 o'clock arrives and you remember that it's your final day on rotation and you have a feedback session with your attending. Dr. Klein and colleagues from Emory University looked at just this by performing assessment of the ACGME milestones. And in a retrospective study, they evaluated 3,600 faculty evaluations from approximately 700 internal medicine residents during the time that residents spent on general internal medicine, general inpatient internal medicine. And what the study authors found was that PGY2 female residents scored significantly higher in 4 out of 6 core competencies compared to their male colleagues. But then by that PGY3 year, it was actually male residents who were scoring significantly higher than female residents in 5 out of 6 core competencies, with the additional competency between the two being medical knowledge. And the study authors found that there was this significant increase in male resident competency between PGY2 and PGY3 that was not seen for female residents. And they found it was actually a peak and plateau phenomenon for female residents, and hypothesized that there very well may be a metaphorical glass ceiling that exists for females during training. And the study authors also hypothesized that during that PGY2 year, when females are developing their leadership style, it can be much more communal. And then when jumping to PGY3 year, the expectation becomes that it will be much more agentic or capable of that independent autonomous action. and that females likely have a likability penalty placed against them in the third year of residency that male residents do not. So you receive the following feedback. Use more open, approachable body language. I was intimidated by you. I had a difficult time reading you. And a bit malignant at times, really made me feel like I was beneath her. Now I want you to internalize what it would feel like to receive these comments. These are all comments that exist in the MedHub evaluations of our own female internal medicine residents. And I want you to think about what it would feel like to receive these comments and then know you had to go on and continue to care for patients. So 4 o'clock arrives, the end of the day is in sight, and you head to the resident library to give sign out. You're signing out to one of your PGY2 female colleagues who happens to be a pregnant female. And in that moment, you start to think to yourself, would I be capable of being a parent in residency? And what would that look like? In a large survey study performed at Stanford University, among all of their trainees, including residents and fellows, study authors were able to identify 3 major things. The first is regarding professionalism. Female residents were far more likely to perceive a negative professional perception if they were to become a parent in residency, and that there would be a penalty against their professionalism. The second was regarding career, where female residents felt that becoming a parent in residency would adversely impact their future career. And finally, collegiality. Female residents felt that becoming a parent would place an undue burden onto their colleagues. Now, these perceptions have been proven to be a reality. Dr. Krause and colleagues at Mayo Clinic also analyzed a very similar question. But through a retrospective study of their own internal medicine residency, they found that females in the postpartum period actually receive negative feedback as compared to their male counterparts. And this was negative peer evaluations. This is known as the motherhood penalty, and it exists for our female trainees. So let's review some concepts. You arrive to work and you are mislabeled almost instantly. You faced role incongruity when having to be assertive in patient care communication. You were a stereotype threat when running a code. Your learning environment was fraught with multiple interruptions from a male colleague. Your performance assessment demonstrated that you peaked and plateaued and actually might be creating a toxic work environment. And finally, you thought of the motherhood penalty. And as you can imagine, this can all impact the psychological well-being of our female trainees and can lead to substantial degrees of burnout. And all of these things are interrelated. None exist in a vacuum or alone. And our female trainees can experience one or all of these things in addition to a multitude of other biases in a single day. So now let's move forward and look at trainee career advancement. One of the things that we know is so important is mentorship. This has been studied many times. And we know that mentorship is important for the following reasons. It impacts residents' career choice, an interest in academic medicine, personal, professional, and social identity. And finally, the time engaged in scholarly activity. And in a 2008 study performed at the University of Pittsburgh, study authors utilized focus groups in order to talk to internal medicine and OB-GYN residents and understand a bit more about mentorship identification. And the study authors found that male residents are more likely to identify mentorship through the following ways: research opportunities, networking, and similar interests outside of medicine. Whereas female residents are more likely to identify mentorship via word of mouth or work experience, including what is known as chance circumstances of being paired with an interested faculty member on a clinical rotation. Now, I started to think about this anecdotally. As a female resident wanting to identify female mentorship, I wanted to think a little bit more about those chance circumstances. And so I thought about our 4 major inpatient rotations at the university hospital: general internal medicine, hematology, cardiology, and pulmonary critical care medicine. And I wanted to know, what is the chance circumstance that one of our female trainees could be paired with a female faculty member when on any of those given services? And so I looked at data from June of 2020 until current, and found that if one of our female trainees was on hematology or general medicine, they had a 50% chance of being paired with a female faculty member. Now, this number substantially decreases when you look at cardiovascular medicine, down to 24%. And it continues to decline when you look at pulmonary critical care medicine or our MICU experience, down to 21%. And this is important because mentorship can impact research productivity and scholarly pursuits. And in a large survey study of residents, study authors found that female residents are less likely to be involved in research during residency, have fewer publications regardless of the author ordership, have fewer national presentations, and fewer international presentations. And mentorship and research are so key to understanding career selection. There have been many studies that have shown that the factors important to career selection for internal medicine residents are as follows: personality traits, educational experiences, mentorship, economic incentives, and finally, this perceived work-life balance. And in a large survey study performed by Dr. Gavinsky from our very own division of hospital medicine, her and colleagues at UT Southwestern partnered with Northwestern to survey 292 internal medicine residents. And what the study authors were doing was looking at confidence levels, and confidence levels in the 3 following domains: clinical skills, communication skills, and procedural skills. And they looked at confidence levels in a survey based on a 1 to 9 Likert scale. And then they went on to assess procedural versus non-procedural career selection, with procedural being the big 3: cardiology, pulmonary critical care medicine, and gastroenterology. And Dr. Gavinsky and colleagues found that residents planning to enter a procedural specialty had a higher mean confidence and a higher proportion of men. And these higher mean confidences were across all 3 domains: clinical skills, communication skills, and procedural skills. And it was men that had higher confidences in each of those domains. And this is important because you look at the national fellowship selection, and what I told you a little bit earlier regarding the 3 specialties within internal medicine that are deemed to be communal, they are endocrinology, geriatrics, and rheumatology. And you can see that on a national level, all 3 of those specialties, based on the AAMC 2019 data, far exceed the 50% female. But then when we look at the procedural specialties, like gastroenterology, pulmonary medicine, and cardiovascular medicine, we drop to a 1/3 and below. And so I started to think about this, And I wanted to know, how do we in our own residency program compare to these national averages? And looking at data over the last 4 years from our own program, you can see the following trends. Again, the national is represented here in this blue color, and then UW in the red bar. And of all of the residents that we have matched into endocrinology in the last 4 years, 100% have been women. Now, we are below the national average in terms of geriatrics, and that's because we match many men into geriatrics. We're above the national average for rheumatology. And then we start to dip again when you look at gastroenterology and pulmonary medicine, almost half of the national average. I don't have a clear answer as to why this is happening, but I think back to mentorship, those chance circumstances, and research and scholarly pursuits, as well as those confidence levels. And finally, one area we're doing very well is cardiovascular medicine, where you can see we're almost twice the national average. So now we're going to move into the final portion of my talk and look at ways each of us can improve gender equity in training. First, I want to say what I'm doing differently. I'm using my voice as a catalyst for change, and today is a perfect example of that. And something so near and dear to my heart and that of my co-chief residents pictured here is mentoring future generations. I have been deemed the intern champion, and part of that has allowed me to provide mentorship to many of our intern class, which has been some of the greatest joy over the last year. I'm also working on creating a Women in Leadership and Development program, also known as WILD. Along with my colleague, Dr. Dana Lai, a PGY3 in internal medicine who has matched into gastroenterology fellowship, and with our faculty advisor, Dr. Cheda, the Associate Dean of Medical Education. And with administrative support from Kara Westmiss, we are building out this program. Now, WILD programs have actually existed on a national platform for many years. And Dana and I became aware of this in the last 6 or so months. And UCSF has a very robust WILD program. And they started in 2016 and actually published on it in 2019. And similar programs exist at other major institutions, both locally and nationally. And so Dana and I have been in ongoing conversations, and we've actually created our own program, AIM. We want to provide trainees with a toolkit for career advancement while concurrently targeting skills to negate the systemic gender bias that I have discussed today. Our timeline is that we will be piloting this to the Department of Medicine Fellows this upcoming July, with the goal for expansion to the internal medicine residency during the following academic year. And we are creating a longitudinal curriculum with 8 to 10 skill building and didactic sessions over some of the following topics, like advocacy and empowerment, navigating difficult conversations, and conflict resolution. So what are things that you can do differently? I want us all to work towards creating a more inclusive environment. Be aware of your own implicit bias and check your gender stereotypes. Avoid gendered letters of recommendation. And ensure that women's voices are heard by role modeling professionalism and providing sponsorship. You have the ability to stop those micro and macro aggressions as they occur to our female trainees. And if not in real time, allow for a debriefing session. So what are things that the internal medicine residency can do differently? We can ensure that the percentage of female core faculty approximates to 50%. We can also ensure that the percentage of females on the clinical competency committee and associate program directors approximates to 50%. Now, remember I told you that sweet spot in critical mass theory was 30 to 35% of faculty members. But then I showed you that within our own department, we far exceed that. We're already at that 46% mark. So let's just elevate our bar a little higher and get to that 50%. And finally, we can create a formalized coaching program and longitudinal research curriculum to ensure career advancement and scholarly pursuits. These are two things currently being worked on by chief residents and APDs. And what can the Department of Medicine do differently? So something that occurs at UT Southwestern with a variation at UCSF and MGH is a celebration of Women in Science and Medicine Day to give accolades to our trainees. We can also create a formalized mentorship program for women in medicine. And finally, author an I'm With Her quarterly newsletter to highlight the outstanding work, presentations, and awards of our trainees and faculty members. This already exists at Thomas Jefferson University and here within our very own Women's Health Fellowship. So what are 3 things you can do today? I want to leave you with these 3 things. The first is listen. And I mean really listen. Listen to the voices of your female trainees. Respect what they have to say. Reflect on what they have to say. And amplify their voices in places they might not be heard. The next is communicate. After this, I encourage all of you to pick up your phone, text, call, page, email. Let your trainees, past and present, know that you are there to offer support, that you celebrate them and you honor all of their many accomplishments. And finally, get involved. Sign up to be a mentor for the WILD program. Volunteer for a networking event, or volunteer to teach a leadership skills. So thank you so much for listening today. I want to say a resounding thank you to everyone included on this slide who have contributed to my content or watched this presentation ad nauseum. Thank you so much. I also want to say an individual thank you to Dr. Jessica Tischendorf, who has been my mentor throughout this entire process. For those of you that are wondering, I did say yes to the dress at a very different bridal boutique, and my husband and I were married in June of 2017. And then pictured here is my family, my parents and my sister. My parents are hopefully here virtually today from Utah, and my sister from California, and my husband in another room of our house. Thank you all so much, and I love you. So with that, I will take any questions.
Great. Well, thank you, Dr. Donahue. It was a wonderful talk. It's an area that I am very passionate about and will help in any way possible. I will say one of the things that influenced me in taking this position was the fact that more than half of the clinical chairs of the departments are women here, which is really unique. This is, of all places I've been to, I think a very supportive institution for women. But we still have opportunities.
Yes.
Great. There is a comment from John Frona about your outstanding talk, and then talking about, on a positive note, related to milestone scores in a study that was just published in Academic Medicine. The scores reported by the clinical competency committees to the ACGME do not show signs of bias related to gender for medicine residents. So I think that is a step in the right direction.
It definitely is.
So one question from Dr. Lin is, What specific advice would you give for faculty when writing letters of recommendations for female trainees to avoid gendered terminology?
Thank you so much for that question, Dr. Lynn. That's a really difficult question, but I think one of the things that you can do is just write that first draft and then remember this talk and remember what I talked about, those implicit biases that can exist in our own language. And after you write that first draft, go back and revise it and see if there's anything that you might have been missing or may have put in that could have led to a more gendered letter of recommendation. It's tricky, it's not easy. These words are ingrained in all of us. It's what society uses to describe men versus women. But we can change that, and we can make sure that we level that playing field for everyone.
Yeah, and I will add two things. One thing that I became aware of is a discrepancy between referring to men as Dr. so-and-so versus referring to women as Sarah. So one thing I am very intentional about is making sure in my letters, it's Dr. Donahue, and in introductions, it's Dr. Donahue. There are also websites where you can put your letter in, and it will review the content and tell you if there are gender terms being used in your letter.
That's wonderful.
Yes. Okay. Oh, yes. So there is in the chat, there is one of the websites. There's a couple of them. I think they all have some good information. So really wonderful job. I am delighted that I'm here representing department chairs, women in pulmonary and critical care medicine.
Yes.
And we will continue to work on this. I mean, it's a work in progress, and it's something that I'm strongly committed to. So we look forward to moving forward with Wild Women.
Yes, Wild Women it is.
Okay. Well, thank you, everybody. And I hope you have a wonderful weekend and enjoy the warm and muggy weather.
Thank you.
Take care.